Well, let's not forget about chemotherapy and advances there. I'd like to talk about liposomal daunorubicin cytarabine. Rami?
Sure. So CPX-351 is a liposomal cytarabine daunorubicin that's packaged in a way that allows delivery of 5:1 molar ratio of the drug, better bone marrow penetration, leukemia cell kill in vitro at least. We did the phase 1, phase 2 studies, and there was a signal of survival benefit in patients with secondary AML, a term used to combine therapy-related AML as well AML from antecedent hematological diseases. So the phase 3 randomized clinical trial led by Jeff Lancet randomized patients that had either therapy-related AML or AML from MDS or AML with MDS-like cytogenetics, randomized patients between the CPX-351 and 3+7, the standard chemotherapy, and showed a survival advantage for CPX-351 over the intensive chemotherapy, higher remission rates, and a 1-year survival in the range of 40% versus 27-28%. So the drug was approved in that setting for patients with secondary AML. And obviously, I think it still goes through what we've been discussing. I think in my mind, I think I go through the same exercise. If I decided to induce a patient, that this patient is candidate for intensive chemotherapy, and the patient happens to be a secondary AML, then I will use CPX-351 over 3+7 in that setting. So that's how I position the treatment. At this ASH, we've seen some subset analyses about from the original study. The original study, by the way, included, I think, 300 patients, we saw data on the molecular profile for those patients and how did they fare. And again, not all the patients on the study had samples, and those were not serial samples, so those were like just a diagnosis. I think the message from that is that probably patients with P53 did not do well as well. So the patient that had P53 mutation on the study, the response rate and the overall survival looked same like 3+7. And I think Mark had alluded to that, and I completely agree with him. It's my practice. If somebody has P53, I go away completely from intensive chemotherapy. I don't give intensive chemotherapy, even if they are younger patients. So the message from the molecular analysis was like that. The other groups were small to really make a firm conclusion. And in some of the subset, they looked at the TET2, SXL1 mutated. The CR rates seemed equivalent, but then there was some survival advantage. I really don't know what to make up out of that data. The only thing I can say is in the P53, again, I think the message should be, we should be enrolling those patients on clinical trials, novel combinations. They don't do well with intensive chemotherapy. There was another analysis done as looking at the patients with AML, with MDS-like changes that got consolidation and got to transplant. And again, there had been this signal in many of the studies, subset studies, looking at patients that, even the patients that go into remission, when they get consolidation with CPX-351 compared to 3+7, or they go to transplant, their outcome had been better with the CPX-351. And people are speculating about that. Are we achieving better MRD status or not? So there was a landmark analysis presented at this meeting as well for that subset of patients, and showing that patients that went to transplant, again, receiving CPX-351 in the induction consolidation with 3+7 did better with the transplant.
But I think the thing with CPX-351 that I'm seeing cause some confusion amongst practitioners is your secondary AML. Is the patient borderline fit for intensive therapy? Are you going to use a HMA-VEN, or are you going to use CPX-351? The data would suggest that CPX-351 is clearly associated with, if you're taking an intensive route, and maybe even transplanting the patient is the approach, and yet there's this kind of default, well, I'm going to go do HMA-VEN because it's easier.
And as Harry pointed out, a significant percentage of patients who weren't thought to be candidates for intensive chemotherapy in the setting of HMA venetoclax went to a transplant and have had good outcomes. What I find interesting about CPX is that, it already has a pretty narrow indication, and now we're supposed to say, okay, well, it's secondary AML and it's treatment-related AML, but not the P53s. It's just, I feel like, the message is it's chemotherapy, right? And the same rules apply to, standard, it seems as if, that this, the risk factors for poor response to chemotherapy are pretty applicable to CPX, and it's just kind of chipping away at the patients who should
but
get.
I'll remind you, in that phase 3 study that was for patients 60 to 75, so not young people, more patients were able to get to transplant. And although it's a completely different study, more patients than in the HMA-VEN studies went to transplant, of course, different studies. And the outcome after transplant was superior than after chemotherapy. So I think it comes down to a very long conversation. While you're waiting for this mutational data to come back, figure out what your patient wants. You know, the 70-year-old, are they looking for maintenance therapy and just, living another year? Or are they looking to be cured? And if it's a curative route, then I use chemotherapy, and I think liposomal daunorubicin cytarabine has an advantage there if you're going to take them to transplant. It's a long discussion. Yeah. But if they do get an HMA-VEN, don't forget about the value of transplant.
Yeah, a remission, it may buy you, a similar, I mean, this is a big maybe. I don't know the quality of a remission after a lower intensity therapy versus a higher intensity therapy and how that might, be cashed in for a post-transplant outcome, but it's a provocative consideration right now. And if you're in that situation, Harry, I agree, don't rest on your laurels. That may be someone that could go on and benefit.
Well, interestingly now, are we going to think about maintenance with orals after CPX? So there's going to be, I'm just throwing out there because that, is going to come up next.
Or after HMA-VEN. I mean, any remission may be amenable to a maintenance,
That's right. And now that it's available, we need to be able to study this, or will be available. Okay, so before we leave this section, just one word about another drug that was approved in the last couple of years, glastigib, the hedgehog inhibitor, approved based on a randomized phase 2 study in older patients unfit for chemotherapy, low-dose cytarabine or low-dose cytarabine with glastigib. There was a longer survival, almost double up to from like 5 months to 9 months. There was a higher remission rate with the combination with glastigib. I think it's not really caught on, at least in my practice and what I've seen, partly because, and I know we're not supposed to do this, but when you look at the data with the HMA-VEN and LODAC-VEN, the responses and duration of responses appear greater. And there is some GI toxicity, hair loss, and muscle cramps that you see with it. So hopefully the phase 3 studies that are being done will be designed in a way will show the actual benefit of this drug for our patients.